I've tried to strike the right balance between content that directly relates to laboratory medicine and some broader clinical examples that I think illustrate really important points that will still apply to laboratory medicine. So just briefly, I'll talk about a little bit about the epidemiology of so-called medical error and patient safety, and then a little bit about different approaches to measuring the problem, and then talk about some recurring themes in trying to tackle these problems, and some key targets, I think, for clinicians and laboratory medicine people to work on together. So a little bit of some sensational stuff. This was what you mostly heard about in medical error until this big Institute of Medicine report came out. This first case actually happened the year that I moved to the Brigham. This was, some of you may have heard, oh, the second one, yes, is indeed a doozy, and we actually discussed that at length in the book. The first case was a reporter was doing a story on the wonderful care she was receiving at the Dana-Farber Cancer Institute and then died of a 10 times overdose of her Cytoxan. And actually that incident led to the very progressive and proactive role that Brigham and Women's Hospital and Dana-Farber have taken on patient safety. The second case, this is sort of a classic case of there's the initial story and our reaction to it, and then what actually happened is incredibly complex, and probably this neurosurgeon had been the head of neurosurgery at Cornell and was then sent to another hospital as a result of sort of being blamed for this incident, which really, we discussed it in the book. I mean, he was referred to patients with long Indian names, was all he was told about one of them, and they both were being operated on the same day, and actually probably the wrong MRI was in the operating room, and so on and so on. The truth always ends up being more complicated. Nonetheless, he was sort of held, the one closest to the patient or holding the scalpel usually takes the blame. In any case, it turns out to be more interesting than that. Another one that probably everyone in this room may remember, early 2001, this was this case in Philadelphia where they were measuring the right PT, but they were using the wrong ISI, and so they calculated the wrong INRs, and this was implicated in the deaths of at least 3 people and probably prolonged hospitalization and care for a lot of other people. When I was living in the US, I got a kick out of keeping track of stories from Canada, and this one actually happened, I think, in Saskatchewan, but was reported out of Winnipeg, where I'm from. This woman was trying to go through the airport medical detector, and it kept going off, kept going off, kept going off. I don't know what they finally did to her, but she had had unexplained abdominal pain for 4 months, and actually when she finally got the x-ray she probably should have had all along, they found a very large retractor in her belly. And actually this one is not just isolated headlines. There was a story in the New England Journal of an article in the New England Journal of Medicine where they analyzed the risk management database. So this would actually be an underestimate of the problem, since these were only cases they knew about from lawsuits. And they found 54 cases of retained sponges and instruments over this 16-year period, and that boiled down to about 1 case per year at a typical large hospital. This is pretty standard. Definitely every hospital I've been at has had a case or 2 of this, and we decided to use that for the cover of our book. So even though none of us are radiologists, this is not supposed to be in the pelvis. But in 1999, there was a definite change in the types of headlines. So this is no longer isolated cases. There was a series of headlines reporting that medical error was the 8th leading cause of death in the United States, and some of the headlines carried specific numbers, 44,000 to 98,000 deaths per year in hospitals alone. And in fact, these headlines were not exaggerating. This was a report from the Institute of Medicine, as we all know, an august body of largely famous researchers who had put together data from a number of studies and shown that if you take, I'll explain the estimate in a second, but basically 44,000, if you take even the lower bound, that actually beats out motor vehicle accidents, breast cancer, and AIDS as causes of death. Now, just briefly where these numbers come from. So there was 2 seminal studies, both conducted by teams of researchers from Harvard, though interestingly they conducted neither of the studies in Massachusetts. The first one was in New York State in 1984. They screened 30,000 admissions. I believe the only exclusion was psychiatric admissions, and then they did a similar study in Colorado and Utah about 10 years later. And basically what they were looking for was bad things that happened to patients that weren't due to their underlying disease, and they called those adverse events, or what we've all historically called iatrogenesis. So they found that roughly 3% of all hospitalized patients experienced an adverse event. In other words, let's say they had a pneumothorax and it wasn't because of the pneumonia they had, it was because of the central line we tried to put in, or they had a reaction to one of their medications. Now these are not, obviously, they're not all errors, but they were looking for the subset that would be. they found that these 3%, as I said, had an adverse event, and then somewhere from, say, 6 to 13% of those patients died, and half of these were preventable. Now, so what they did to get that 44,000 to 98,000 was, if you basically multiply these out and then multiply that by the 30 million hospitalizations a year in the United States, you get, well, actually, you don't quite get either 44,000 or 98,000, which is a little bit mysterious. But in any case, you get something in that range, and that's how they generated this estimate. It's probably, there are problems with this estimate. I mean, for one thing, it's just worth pointing out, these are not the wrong sides of the brain being removed. These are people with clots and infections and other things that they're certainly important, but they're not the wrong brain, the wrong leg, anything like that. The other problem is there's no real causality here. I mean, lots of people will have an adverse drug event, a reaction, and if you're in a tertiary care center, 3 or 4% of those people will die. The question is, did they die because of their drug rash? Well, except for, the really rare case of Stevens-Johnson syndrome or something, it's not going to be. So the causality is not clear. And then this, even putting aside where they actually got the 50% were preventable number for the report, there is notoriously poor agreement between reviewers on whether something was due to an error or was preventable. That said, it's still worth pointing out that, first of all, we haven't paid too much systematic attention to iatrogenesis or adverse events in healthcare. It's not in any systematic way. And also, these were just deaths they were talking about, and they were just hospitalized patients. So if all that happened to you was something really, really bad short of death, you weren't included in that 44,000 to 98,000. So I think it's still worth saying that this is a problem that needed to be looked at much more than it had, and the Institute of Medicine succeeded in putting it on everybody's radar screen, where it probably should have been all along. But do we know anything about these rates of errors and adverse events in the clinical lab? Well, I'd say yes and no. I mean, the major adverse event studies have not looked at this, and I don't think realistically they could have. I mean, I've had some experience looking at these chart reviews, and even when the lab's not involved, it's really hard to tell sometimes what went wrong, or even that something bad happened, and certainly it would not be likely that anything that involved any kind of detail involving what went on in the lab would be reported in the clinical chart. That said, as a field, I think lab medicine is actually quite an impressive record, especially through the College of American Pathology Q probes, of systematically studying multiple aspects of the laboratory process as it relates to clinical medicine or just as a laboratory in itself, to document error rates and potential quality problems. And even though in clinical medicine, anesthesiology is often held up as sort of the poster child for patient safety and having improved their record over a number of years, actually laboratory medicine has a quite impressive record of its own, especially when it comes to more general quality improvement and applying the sort of industrial style quality improvement that you hear about a lot, continuous quality improvement and so on. So I think in many ways a lot of these studies are already out there, although I'll still talk a little bit about some important lessons. This was a recent review article in Archives of Pathology and Laboratory Medicine just in October of 2005 that shows some of the results of these Q probes, and the specific results are not so important in themselves, but just to show you that they really have looked at error rates from relatively mundane but important things like phlebotomy dissatisfaction or incomplete venipuncture to more important problems like incorrect patient identification, which I'll talk about later, erroneous messages, failure to have proficiency test failure, and so on. But I think there's about 140 of these Q probes out there. I mean, many of the people in the room will know those articles better than I do. Even though lab medicine, I think, has a very good record studying the different important components of the processes you do every day, there are still some important lessons, I think, to be learned about approaching measurement in general. I'll talk briefly about incident reporting, proactive surveillance, triggers for chart review. And the last one I won't really mention, but it's basically kind of neat. Some colleagues of mine in Ottawa and also in Nashville have developed a natural language screening of discharge abstracts, x-ray reports, and so on, and tested them and found them to be not super sensitive, but very specific for identifying complications of care. So you just sort of like almost doing a Google search or something on all your text-based transcriptions, and there was about a 25% sensitivity for true adverse events, but very high specificity. So if all you wanted to do was have a quick way of identifying potential problems of care, this may be one of them. In terms of incident reporting, I mean, basically, it's a terrible, useless almost way to capture safety problems, but they're mandated and they're cheap, and management often likes them. The reason they're so bad, I mean, it's been shown in a number of studies where they have had better information that only about 5% of bad things ever get picked up in incident reports, and they're not even important problems necessarily. And so it's really like a very poor way and probably biased away from the most important problems. If you're going to do it, though, I think the key message is to not be distracted by a lot of the fancier programs that are out there, and that several hospitals that I've worked at actually pay quite a lot of money for. So what tends to happen is people will get attracted by the idea that we can have web-based reporting and produce some fancy reports and see that there were 100 incidents over the last year, but they're really almost meaningless as reports. I mean, first of all, they're numerators in search of denominators. You have no idea what the real population at risk was. And often what ends up happening is you extract almost painful amounts of details from these users who've already gone to the trouble in the middle of their busy clinical work to try to report something, and then you're asking them, and what category of this do you think it was, and what type of harm do you think it was, and this and that and this and that, and by the end they're obviously not interested in reporting anymore. And frankly, 6 months later, when you get this fancy report on your desk, you can't figure out what happened. As I mentioned before, a lot of the charts don't have any indication that something bad happened, certainly not why it happened. So I think the key thing is really just to establish in whatever area you work, whether it's a clinical area or the lab, these are the 5 to 10 types of incidents that we'd really like to know about. Just tell us, you know, the patient's name, where it happened or when it happened, and maybe 1 or 2 sentences about it so that we can screen them and say, look, this is something, this is beyond my dinner was cold, or I got my Tylenol an hour late, or whatever it is. This is really serious. I mean, and they're not all such petty reports, but some of them, they're just more of the same. You don't need, especially in the clinical areas, you don't need to know that yet again someone fell out of bed. I mean, that has moved beyond the incident report stage. You could now do a systematic study at the hospital level. You don't need to just keep hearing about that over and over again. But you might decide, for instance, laboratory medicine, anytime there's a patient swap, I want to hear about it. You just need 1 sentence to hear about that, and then you have almost like a SWAT team to descend within 48 hours on the incident and figure out what happened. And the key thing also is don't invest a lot in one of these systems and then not actually fix anything, because morale will die very quickly and you will get even fewer incident reports the next year. Alternatives to incident reporting, one of them that I'll just briefly mention, which I think Mike and some other people here have tried, is this idea of more actively searching, sort of prompting people to make incident reports. So one thing you could do is visit periodically, once a week maybe, clinical areas and just say, has something that you've been dissatisfied with the lab happened recently? Or could you identify, and then you also just tell them, and anytime you get a lab result that you think is suspicious, just let us know and we'll take it from there. And the one example study from 1997 on errors in a stat lab was they did basically what I just said. They went to 3 or 4 different clinical areas and said, they kept going out there really trying to be user-friendly, say, just let us know if there's any important lab results that you think are suspicious looking and we'll investigate them. What they found was a 0.5% error rate when they actually verified these suspicious results the clinicians had identified over 45,000 results over a 3-month period, and 6% of the errors affected care. Now, I'm not trying to prove whether the error rate is bad in laboratory medicine, but it is important to point out that that error rate is per test, and not per patient. If you assume that most of these cases were not happening, one patient's not going to have 5 errors happen, and they're probably just going to have 1. So the actual denominator should be lower, probably by a factor of 10 or 5 to 10, depending on how many stat tests the patient might have. So it's a good error rate to have, an error rate of only 0.5%, but at a patient level, it might actually be higher than that. And more importantly, I think it's just worth noting that this is a more efficient way of identifying safety problems than just waiting passively for people to report a problem. But it's still a lot of work to go out on a periodic basis and say, please report all your problems to us, we're really interested. And it's not something you want to do all the time. So I think the idea of using triggers is much more promising, and that's something that actually there's been a couple studies from here and elsewhere where you design triggers based on existing data to alert you to potential safety problems. I've given deliberately two non-lab examples here. For instance, if you just wanted to know how badly clinicians are doing with anticoagulation, you might just screen all the INRs greater than 7 and try to look into the explanations. An insensitive but very specific one would be the second one I gave you. If any inpatient receives Narcan to reverse opiates, unless they're in the emergency department, it suggests they've been given too much morphine or whatever narcotic. So that's not a frequent problem, but it's a serious problem, and you might want to, this with a push of a button, you could essentially identify these cases and look into the explanation. And a laboratory example would be from a study here, actually, quite a nice study. I gather it was a resident who was the first author, and I think Mike was the second author, using corrected reports as triggers. So again, instead of just passively waiting to see if someone reports something, you're just going to say, look, among our existing data, we know there's corrected reports. Why don't we have some easy screening criteria to say which ones are more than just cosmetic changes, such as removal or addition of an organism from a sterile site to the report, or changes in something that clearly could have reflected care. You could rapidly screen those on a daily basis and then go investigate the ones that really look serious. And when that was done, they identified that 6% of the 148 corrected reports seemed to have some kind of impact either on patient care or on the patient themselves, and the causes are here. And this won't go into what this one was, but it did sound like a pretty serious case of morbidity, these 5 ones too. And all of these ones, I think you can see that there's some unnecessary procedure or test, unnecessary or inappropriate drug therapy, and so on. But the point is not to say, again, the point is not to say, see, there's a bunch of screw-ups that affect patients. It's actually just to say, look, this was a very efficient way to gauge whether or not there was a serious problem. You might decide that actually, well, we're doing pretty good here. Or you might say, well, one of these categories looks serious, let's look into it, or keep track of it on a yearly basis. The point is that this is a much more efficient way of identifying problems than waiting for reports to come in or actively going out and doing case finding. Another interesting trigger, this was a study that came out just a few months ago, is using cytologic histologic discrepancy. So this obviously is an anatomic pathology, not in the rest of laboratory medicine. But the idea here being that, again, amongst your existing data, you would have these cases of patients who've had cytologic samples and then biopsy material from the same site within 6 months. Why not screen them to see where the diagnoses were not the same? And again, you would avoid the cosmetic differences or the trivial ones or the ones that just reflect differences in the classification systems in cytology from histology, and then you get to the subset that there might be something there and potentially investigate them. And when this was done as part of an AHRQ-funded study, there was 4 sites, and I think at one of the sites maybe only one pathologist was reviewing it, but the other one was 2. They tended to get arbitration by the original pathologist, and they rated the discrepancies according to their potential significance. And what they found was that, and they split it up as gynecologic versus non-gynecologic. So when you use the discrepant cases as the denominator, 4% of them looked like they had some kind of significance, and when in non-gynecologic it was closer to 11%. Obviously it was a much lower rate in both cases if you use all cases as the denominator. And then they went on to rate the harm actually was around 40% in both cases, and they actually distinguished how much of them were sampling error and how much of them were interpretive error, and it sort of flipped, 60% sampling error for the gynecologic one and 40% interpretive versus 70 and 30% for the non-gynecologic one. And what was interesting, so first of all, again, the point is not to say, again, here's proof that the laboratory medicine people are making mistakes. It's to say, with almost a push of a button, they identified a trigger that they could efficiently identify areas that would be enriched for potential problems, and then they could decide whether or not they actually were having enough impact that they would go on to fix them, or, as I'll talk about later, whether there really is a strategy for fixing them, or you may just have to accept that occasionally you'll make a mistake. And in this case, and I'll talk about some of the specific interventions, there were a number of very specific process improvements that each of the institutions made to address some of the specific sampling errors and some of the interpretive errors that were recurring. So basically, just summarizing a little bit on the epidemiology and the measurement, incident reporting, if you're going to do it, it really should be bare bones and quick. Don't get distracted by a lot of bells and whistles and having a fancy program that produces cumulative reports every 6 months. Just find out what certain types of incidents were and go investigate them quickly, and consider looking more proactively for cases by, for instance, soliciting input from clinicians, visiting clinical areas. And I think even more promising, though, is this business about using triggers, that well-chosen triggers can really efficiently identify cases using existing data so that you don't have to depend on other people doing extra work, almost out of a good citizen type of spirit. So I'd like to move on to talking about some recurring themes when it actually comes to fixing some of the problems that you've identified. And 3 of them that I've chosen here is the mismatch of problems with solutions, inattention to workflow leading to what are called workarounds, which often create more problems than they solve, and then communication and teamwork problems. So I'll just actually start with a case. This one is not directly relevant to the lab, but I think there's enough relevance, and it really illustrates cleanly a certain type of problem. So this is a case from the series in Annals of Internal Medicine that Michael mentioned, and we get colleagues from around the country to submit cases, and they agree to be interviewed for it, and we had de-identify it, obviously, so there's no concern. And they're presented in the format of the case records of the MGH, the New England Journal, except that instead of like, isn't it fascinating that this patient had this rare disease, it's the dissection of a systems problem, usually that resulted in some major safety or quality problem. So in this case, this was an elderly patient who had undergone bypass surgery and had a complicated post-op course, but was finally doing really well and was ready to go to the floor, and then had a grand mal seizure just after team rounds. And the team descends on her, fires off the shotgun set of labs, and intubates her after giving her sedation. And then as she's down in the CT scan that they sent her to rule out a bleed, the serum glucose comes back as undetectably low. So they give her an amp of D50, the sugar barely bumps, give her another amp, barely bumps. So it strongly suggests the presence of insulin, and again, this patient is not diabetic. So further investigation of the case revealed that the patient's arterial line had occluded, frequently and required a lot of flushes, and a nearly empty vial of insulin was found on the work table outside the patient's room. So it's very likely that the patient's line was flushed with insulin instead of heparin, resulting in this undetectable glucose, and the patient did eventually die as a result of this. So this was, we didn't obviously have a picture from the actual case, we just assembled these medications, a typical bedside table. So in the front, this is what the heparin multi-dose vial looks like, this is what the insulin looks like. I mean, to us sitting here in a talk and not in the middle of work, they don't look that much alike maybe, but they look maybe more alike than the other vials that are up there. And they must look somewhat alike because this was a newspaper story that came up by coincidence around the time that this case was being prepared. This is an identical error at 2 hospitals where in both cases someone's line was being flushed with insulin instead of heparin. So the highlights of this case were that the contributing factors were probably that, first of all, this was a unit where they still used multi-dose vials, which a lot of units don't do anymore. There were protocols to return the vials to a locked cart every time that you'd finish using it, but what a big surprise. People found that inconvenient, and so they routinely did leave them on the bedside table. And this is what would be called a routine rule violation or a workaround, so that, yes, the people know they're not really supposed to do it, but they feel the only way to get their work done is to violate this rule. And this happens a lot. I mean, in the ICU, there are often, you'll find people are hiding Ativan under the patient's pillow or carrying it around in their pocket, and basically every 4 years when the JACO survey comes around, they sort of put it away and then they go back to doing the same thing right afterwards. And I'll talk more about workarounds later, but I want to talk more about the actual error in this case, which was the insulin heparin confusion. I mean, it's so basic from a psychological point of view, but in healthcare, we've never really looked at this distinction, and that is that, errors fall into 2 basic categories, what you might call non-cognitive ones or slips, and cognitive ones, which are mistakes. And especially, I think, in any area of medicine, maybe particularly in internal medicine, which is what I'm in, where we don't really do much. We just sort of sit around and try to think about what's wrong with the patient. We really pride ourselves on not making mistakes, but the reality is that most of what we do is fairly automatic, and those errors are far more important. And again, I think in laboratory medicine, the same thing, although actually it may differ in certain areas of the lab. But the idea being that there are a very big difference between making an error in an automatic activity and making an error in something that requires knowledge or interpretation. The difference is, first of all, the risk factors for them or the triggers for them are different. For instance, the slips are more common if you're tired or you're distracted by environmental noise or multiple competing tasks, whereas the cognitive ones, no matter how tired you are, you'll probably wake up to figure out, to interpret the EKG, but if you're relatively junior or it's an unusual case, then you're more likely to make a mistake. And the quality improvement intervention or the safety intervention will be very different depending on this distinction. And just to illustrate that, well, first of all, this was a famous example of a slip recently. Many of you remember the Duke transplant case, where that terrible case of that young girl who'd come up from Guatemala, and was this big sort of publicity thing about all this wonderful work that was going to be done, and then the whole thing is a catastrophe as a result of her getting a basic mismatched organ. And obviously everybody, including certainly the transplant surgeon, knows you're supposed to do cross-matching, but presumably assumed that somebody else had done it, or it's simply in the middle of being called at 3 in the morning to rush in and do this famous case, it just slip by. And so this can be the explanation for even the most catastrophic errors. Some examples actually from Mike's newsletter that I thought were really good for the laboratory. So this was a case that was discussed in one of the newsletters that's produced out of here that Mike runs. This was a case where somebody had entered, the troponin is being run on a different machine and does not have an interface, so requires manual enter into the laboratory information system. And so this patient's troponin result was actually somebody else's, and it resulted obviously in inappropriate care. The patient turned out to have a peptic ulcer but was admitted to the CCU and placed on IV heparin. And this other case was a communication, I believe, of a wrong pregnancy test, where, and this has happened to me actually before looking up results, is you don't notice that it's not the most recent result and actually report the wrong result. So again, it's not like there's a knowledge issue here. This is a simple slip that you would expect on the basis of human perception periodically, and the response to try to make that happen less often would be very different than if it's a knowledge problem. Give an example or an illustration of how bad we have been at looking at this distinction in healthcare. In a non-healthcare example would be, many of you may remember that it used to be that every so often you'd hear about a car accident where someone would start their car, not realize it's in reverse, it would lurch back for it, and they would hurt or even kill someone, often a family member, waiting to get into the car once they get out of the garage. Now, there's two things you can do at that point. You can either reprimand all the drivers after they get back from the funeral of their family member and send them back to remedial driver's education, or you can design the car so you can only shift into reverse if your foot's on the brake. And that's why now, over the last 10 years, you may have noticed that that's why you can't you put the car into reverse if your foot's not in the brake. And so they went with the design solution, obviously, in the automotive industry. In healthcare, if you look at an equivalent situation, it's like every hospital has the occasional adverse event from someone getting a medication to which they have a documented anaphylactic reaction. Now, you can do two things. You can reprimand the doctors and nurses involved and give them an in-service on the importance of an allergy history, or you can design the medication system so you can't administer a medication unless you have clearly looked at the allergy history or obtained one. And we go for the remediation every time and not the design solution. So the point of distinguishing these cognitive and non-cognitive errors, or these slips and mistakes, is clearly that slips can be engineered out, or that's the hope anyway, and they certainly require a different perspective than the cognitive errors. And the different approaches, I mean, there's lots of them, but you might categorize them as environmental redesign, so removal of phones and other distractions, tasks, or equipment redesign. The brake pedal one that I just gave, the classic medicine example is the oxygen yoke in anesthesia. So for many years, occasionally, someone would, instead of getting oxygen by nasal prongs, they would just get more anesthetic agent. Actually, there was an episode of The Simpsons where they had Homer, instead of getting either of those things, he just got the new car smell piped in through his nasal prongs. But in any case, what they finally decided is, there's no point in just reminding people to check. We're just going to design these equipment so you can't attach the oxygen tubing to the anesthetic agent or vice versa. And then process redesign, removal of unnecessary steps, and automation, which I'll certainly be talking about as relevant to the lab. The truth is that none of these is easy. So, I mean, I realize I'm pointing out problems and then pointing out problems with the attempted solution, but this is the reality. Multiple distractions often reflect being short-staffed. So you can say, yes, remove competing tasks, but the reason there's so many competing tasks is we had to fire, some of the nurses or let some of the laboratory technologists go. So it's easier said than done often to create a situation in which you can remove all these distractions. But I think still sometimes you can say, look, someone's job is going to be to answer the phones. It'll be done in a different area, and somebody else will be doing the actual testing testing, or in the case of some of the clinical areas, preparing medications. Equipment redesign is usually not under our control. So that anesthesia example, I mean, somehow they created momentum to get these manufacturers to change. But often, I mean, especially in medications, there are so many medications that have similar sounding names. And even with all the publicity about medication areas, there's no leverage to get people to change those names. Equipment standardization, though, sometimes you can achieve. So on the clinical side of things, this is this issue where on one floor the defibrillator works one way, and another floor it works another way. Programmable IV pumps is another example. So even though you can't get the company to change the design, maybe you could at least get your hospital to order all the same type. That may apply to some extent in the lab, but I'm betting it's not quite as much of an option because you're not going to have quite the same number of pieces of equipment in a single site. Process redesign is under our control, but usually it requires really intensive effort and collaboration with lots of people, so it's not something that can be accomplished easily. And automation, similarly, it's resource and time intensive and requires sustained vigilance for potentially new errors that get introduced. I just thought a little bit about process redesign. This is something Mike talked about this in one of his newsletters. It's sort of a little factoid that you hear about sometimes. It's why elimination of steps and process redesign can be so important. If you consider a typical laboratory or medication-related process, there's usually a lot of steps involved, and 50 is a sort of a decent estimate. And even if each of those distinct steps had an error rate of only 1%, the failure rate for the overall process is actually a staggering 40%. Now, 1% is probably too high for the individual error rate. So if you made it a little bit more realistic and said it was 0.1%, so in other words, the average error rate at each of these steps would be 1 in 1,000. The overall failure rate is still 5%, which is actually close to the number in a lot of those adverse event studies. So this may be actually a decent model of what's going on. Now, what's interesting is that if you want to make some progress, and so say go from 5% to 2.5%, you can either reduce the error rate by half, so go from 0.1 to 0.05%, or you could cut the number of steps by half. And now, I'm not saying that that is so easy to do, cutting the number of steps by half, but it may be easier than actually getting the intrinsic error rate to drop by a half, which can often be very difficult. And so I think that realistically you need to do both, because you may decide that 2.5% is still a reasonably high failure rate for the overall care of a patient, for instance. The way that a lot of processes in healthcare have evolved, because there were so many competing reasons why it got shaped this way, we've sort of evolved these very complicated ways that involve, you know, someone has to fax a request, and then somebody does this and puts it in this bin, and then this and this and this and this and this has to happen, and then finally the test is reported or the patient gets their medication. And so it is tempting to go for process redesign. On the other hand, you realistically cannot bring all the operations of the hospital to a stop. And so you do have to be really careful that when you embark on one of these process design projects that you really are looking at the whole gamut, because otherwise what you may end up doing is making a few changes in here and actually making either no difference or even sometimes having almost a revenge effect where you actually create new problems, sometimes even more than you had before. And there have been some interesting examples recently. Just one of the clinical examples that I find staggering is after the SARS outbreak in Toronto, there was a paper in JAMA that documented that the patients on infection control had this hugely higher adverse event rate, and they weren't getting examined and a whole bunch of other things. It's sort of like, so something that's supposedly supposed to do one thing has this other unintended consequence. There was a prominent paper in JAMA also last year about errors introduced by computer order entering. There's been other ones for barcoding too. So it's just as a general message. But there are still some improvements you can make, and I included this side almost just for fun. I was surprised that this was ever published in a journal article. This is a little cartoon of what's called a lean production diagram, where they, as a result of that discrepancies article that I was mentioning at the cytology and histology discrepancies, they decided that they were having all these problems with urine cytology. Let's look at the sort of Rube Goldberg apparatus we have and actually draw it from arrival of the sample to interpretation. And yeah, they've got all these sort of comical looking stick figures, but the point of it is that these little, they call them hairy clouds, these jagged figures, they call out processes where you would expect some potential for error. And so the idea is that you would target these. And actually in the study, they really did document that in the first year after the study, a number of the institutions did make process improvements. Now, the ones in the first year were not terribly ambitious. They may have made some improvements. So for instance, adding checklists for the specimen preparation and a few other really basic things, some double reads to reduce certain types of interpretation interpretation errors. But in the second year, they launched on some really impressive interventions, including one that I'll talk about later, where they actually went into a gynecologist's office and worked with him really intensively to change the whole specimen procurement from start to finish, and including up to interpretation, and showed some actual reductions in errors that I'll talk about. So in addition to some of the process redesign, better communication is another interesting strategy that has received a lot of attention in the clinical areas recently. And actually, I saw in a couple of the cases that Mike has in the LEPS newsletter, I think would be amenable to this as well. But the handoff problems also as a connection with UW. So the issue is that as the greater fragmentation of the healthcare system, there's so many more handoffs, and that we really need a sign-out system to more formally pass off problems so they don't slip between the cracks. And only 2 systems have ever been studied and shown to have a benefit. One of them was at the Brigham, and the other one is here. It came out in a paper last year, I believe, in one of the surgical journals, but it actually involved medicine and surgery. And as I mentioned, there were several cases in the laboratory newsletter where it was clear that one of the main problems was there was something unusual about a specimen that required attention, but the technologist went off shift, or just like happens in the clinical areas, and there was no standardized way to report, make sure you keep an eye on this specimen, or I diluted this one in a somewhat unusual way, you need to do this. And without some standard way of maybe just even something as simple as saying, these are the handful of things that you need to look at, that might reduce some errors. But realistically, I think major improvements tend to involve automation. So I want to actually talk a little bit more about automation in general. Some of them, I think, are not complex, and it's just a matter of resource. So if you can switch from assays that require manual pipetting, for instance, to automated pipetting, or maybe to no pipetting at all and just a single platform that does everything. But then the more ambitious ones would involve things like barcoding to reduce patient specimen identification errors. So 2 of the changes actually in the case that I mentioned with insulin and heparin involve that type of more ambitious automation intervention. So I want to talk about that. The first one, automated medication dispensing devices, does not directly relate to the lab, but illustrates a principle that's directly relevant to barcoding. So automated, they're Pyxis and Omnicell are the 2 companies. That's not the issue. The issue is just that there are these sort of electronic drawers that you enter the patient name, and a drawer opens and their medication is there. And the idea is that that's supposed to reduce errors. That actually has not really been shown. It's mostly been shown that it helps with inventory. And there's a lot of anecdotal, and certainly personally I've gone and toured a lot of these areas and talked to nurses and pharmacists and so on. And the consistent theme is that you'll find that they're incorrectly filled drawers. You're essentially replacing one type of common error, which is an error in an individual patient that happens fairly commonly, with less commonly an entire drawer being wrong, which is in a way more disturbing in some ways, because it's an arbitrary substitution for almost an unlimited number of patients. And this can happen in a couple ways. It can either happen in the bowels of the pharmacy when they have a pharmacy tech just filling one drawer after another, or there can be spillover during routine use. More interesting maybe is the problem that's come up in every hospital I know of, which is that, there's a saying, if you have a broken system and you automate it, you have an automatic broken system. So what happens with a lot of these systems is you get this thing in, and you still have all the same problems that you had before you get to this machine. And so it takes like an hour and a half, for instance, for the average order to appear in the system. So what happens in certain areas, especially like the ICU, is the nurses just get used to the fact that when there's a new order, they're going to get an alarm. So what ends up happening is, of course, they just routinely turn off the alarm or ignore it. And so then you end up at this system that was supposed to be safer, but in fact now you're just routinely bypassing all of the pharmacy screening that's going on. So of course, when there finally is an allergy that you should be warned about, or this is not the right patient, you're still going to be overriding the signal. And that's a problem with barcoding that has sort of informally, when you talk to people, they find that, especially in the ICU and the ER, that it prevents implementing in some of those areas, because you can't as quickly get the order into the system. And so when the nurse goes to administer the antibiotic, the doctor says has to be given stat, they just get a warning, and of course then they get used to, in certain areas, overriding those warnings. Another problem with the barcoding issue is just the idea that if we can't even identify the patient at the time they get barcoded, then it defeats the purpose of the whole system. This is one of those Q-probe studies from a little over 10 years ago, where I don't know how they got the participation of all these hospitals, but they got phlebotomists at 712 hospitals for every patient to systematically document just a simple questionnaire if there were problems with the wristband. And what they found, the median error rate at these hospitals was 2.2%. So in other words, 2% of patients on average had some kind kind of problem with their wristband, and they're not trivial problems. So half of them, it was that it was absent, which may not sound like such a big deal, but for instance, for the barcoding thing, it just means now what do? You have to sort of go back and call a bunch of people and get permission to give the medication. I mean, the wrong wristband in 0.5%, multiple wristbands with different IDs in 18%, and even all these ones would actually cause warning signals. So you can see this is a disturbing problem if what the whole purpose of what you're trying to do is reduce misidentification errors. Now, there was more recently a follow-up study where they actually, through an intensive surveillance system and feeding back error rates to hospitals, did reduce the error rate to closer to 1%. But you can see that still, if 1% still have some kind of problem at the wristband stage, that's almost like, well, what's the point of getting barcoding? You're almost hardwiring in the error at that point. And in fact, actually, one of the most recent cases of the Quality Grand Round series in Annals of Internal Medicine involves 2 patients who were admitted to a large hospital with both computerized order entry and a barcoding identification system. And one of the patients who's non-diabetic, actually the intern gets called about like a glucose of 400 that was actually from a different patient, obviously, who was diabetic. And what had happened was the patient had their urgent care wristband on one arm, and when they go to give the new, like the inpatient wristband, 2 patients were being made at the same time, and the wrong one got put on the other arm. So this was a potentially fatal near miss, actually. Luckily, for some reason, the intern just mentioned to the resident, and the resident said, you know, that doesn't sound quite right, you better go investigate. So even with the correct wristbands, though, so even putting aside the types of problems I was just talked about, there are some interesting problems that when you implement a new technology, you'll observe. And this was a detailed observational study that came out in one of the informatics journals a few years ago, where they observed the actual process of using the barcodes by the nurses and administering medications. And they found a number of different types of errors, and I'll give a few examples here. So in one case, for instance, a patient urgently needed their chemotherapy, or they were supposed to get their chemotherapy. They couldn't get an IV started quickly enough, and so then they weren't allowed to give the medication because the original dosing time had passed. And apparently, in general, the hospital reported that the nurses now just focused on getting medications at the right time because it was such a hassle for them if this happened. So you're really distracting them now with a new goal that is not clearly related to patient safety. The nurses also thought it was faster just to enter the patient ID I mean, it's sort of funny actually about barcoding. Everyone says it should be so great, but anyone who's ever shopped at the grocery store knows that it's not so infrequent that you actually have an error. They're swiping it over and over again, and finally they do end up entering it manually. And if that happens even more than a few times, people will get used to bypassing it and manually entering it routinely. And amazingly, there was even one misidentification. So even though the whole point of barcoding is supposed to be that you can't have an actual mismatch, it did happen in only about 80 hours, 67 hours of observation. So just want to talk a little bit about workarounds now. So this idea that you would just routinely bypass, like in the medication administration cart, or manual entering the patient ID, or the always keeping the medications out of the cart. From the perspective of the frontline personnel, basically, in order to get their work done, they just decide that this equipment isn't working properly, I'm going to do something another way. And they either create a way of doing it that isn't actually against the rules, but maybe is an at-risk thing, or it actually is against the rules. And so we call these workarounds whenever they're bypassing the safety features of the system to get their work done. One striking example came out with a case on this website that Mike mentioned. One of them is a case-based website for illustrating patient safety concept. This was a case where a husband and wife had come in as trauma victims in a car accident, and at the time of their cross-match, the tubes were mislabeled, and so luckily in this case, the lab tech actually happened to notice that the wife had been at the hospital before for her C-section and that her blood type had changed, which is obviously not possible, and so that was caught. Now what was interesting is that in we get, like I have a letters to the editor thing, and someone wrote in that at their hospital they'd had a similar incident, and the solution had been that everyone needed double cross-matching. Now, not surprisingly, the nurses thought this was a stupid policy, and so they just basically drew 2 tubes from the same venipuncture site on everybody. So in the end, basically everybody's just having a little bit less blood. People are running more tests, and there's 0 improvement. An even more striking workaround is there's a really famous in the clinical area, like lethal error that happens every so often where somebody accidentally gets concentrated potassium, which is actually, as some of you may know, a way of lethal injection when they're executing people. And so this thing called a forcing function has been proposed. The idea is, look, let's just remove the concentrated potassium from clinical areas. That'll prevent the wrong thing from happening. Now, this is obviously not something amenable to study, but everyone just assumes that it's a good thing. But interestingly, on one of the listservs for the National Patient Safety Foundation, someone from Australia wrote in that at their hospital, what happened when they tried that is that people just found it was too long for the potassium to arrive now from the pharmacy in diluted form. So they just sort of stole it from the ICU and the ER and hoarded it. Now there was almost this like black market of concentrated potassium, and the pharmacists just spent all their time chasing after it, which is obviously a big drain on resources, but also was probably even less safe than before, because now you still have the concentrated potassium in the wards, but it's being hidden. So I think that, again, if you don't pay attention to workflow, you're going to have this type of problem. It's worth pointing out that the motivation for workarounds is not laziness. The key thing, if you're just trying to distinguish, for instance, unprofessional behavior from what sort of human nature, it would be that the motivation for the workaround lies just in getting the work done. And I think that the appropriate response of people who are trying to fix the system should not be simply, remember, you're not supposed to do that. It has to be, look, if you're doing this consistently, there's obviously something wrong with the protocols. We need to redesign this in an intelligent way. So, and I think that in general, you need to expect that workarounds will arise whenever you're asking people to sort of work harder for something that from their point of view is an incredibly rare event. Now, after I've talked a lot about problems, some problems do have easy solutions, though. I mean, I've talked a lot about the difficulty of implementing solutions. And here was an example from a WebM&M case where a young woman had come into the ER with aseptic meningitis, and the clinician had appropriately considered the possibility of acute seroconversion and ordered an HIV PCR. What happened, though, was they got the test result while the patient was still in the hospital, and the lab said there was a problem with this batch, but we need to rerun the test, ignore this result. But then the patient was discharged, and obviously the hospitalist is not following the patient, sort of forgot about it, and eventually did come back positive with a viral load of 150,000. Now, the physician had no reminder system in place to track laboratory tests that are pending at the time of discharge, and the lab didn't identify this as important because, as you know, viral loads are mostly ordered to monitor patients with known HIV, so it wouldn't be particularly crucial. When this case was looked at, they realized that, you know what, a simple thing we could do is just indicate on the order form if this is for diagnostic purposes, because it is actually the recommended way to diagnose acute seroconversion, although it would be a small proportion of all the viral loads that get ordered. But if it could prevent a problem like this, it might be worth just having the lab know at the time, this is one that we would want to make sure the provider got the result because it was ordered for diagnostic purposes. I think in general, this case brings up a theme that has come up in a number of the cases I've seen, both in the newsletter produced out of here and in the WebM series and other cases that I just sort of hear about from being in this field. And that is that there are a number of errors that involve clearly the interface between the lab and the clinic. I mean, the pre-analytic, analytic, and post-analytic distinction, I understand why they're important, but realistically, a lot of the pre-analytic and the post-analytic involve things that are somewhat under the lab's control, and you would want the lab and the clinical people to work together to try to reduce some of the problems with the way the order form is designed or the way results are communicated back to clinicians. So an example of a sort of clinic-lab interface problem would be telephone miscommunication. Some of you may have heard about this problem, but actually I'll just give a non-lab example. There was the first case in our Annals of Internal Medicine series involved a patient who was actually the mother of a physician, educated, spoke English, and was taken for someone else's cardiac surgery. This case involved like 15 sort of slips, but the very first one was that it was called, the cath lab called the floor and was told incorrectly, they just used the last name, told incorrectly that the patient would move to another floor, and after that, just sort of a domino reaction was set in motion where this patient was taken for. They were doing an EP procedure, stimulating her heart for an hour before they realized it was the wrong patient. Another case that came up, a critically low potassium called to a floor. The clerk puts the note in the wrong patient's chart, and actually this patient happened to have a slightly high potassium because they were a renal failure patient. So there's lots of other examples, and there was a recent study in American Journal of Clinical Pathology where, as part of an intervention they were doing, which was to just mandate that when critical labs get phoned, they would be repeated back to the person phoning them. This is modeled after aviation and the military, or frankly, even when you order a pizza off, and they'll just say, now this is your order, I'll read it back to you. But it's amazing that in healthcare, we basically said, okay, I got it, Mrs. Jones has a high potassium, thanks. And you go, and what they just documented, the actual error rates they were finding when they were doing this intervention, they found that roughly a third of the time it was being heard as the wrong patient, another third the wrong test, and the wrong test result in 21%. So this would be a relatively low-cost intervention to reduce a problem at the sort of the lab-clinic interface. This was an interesting study, though, another sort of communication or lab clinic interface study from the Brigham and Women's Hospital last year. They were looking at pending test results at the time of hospital discharge. They looked at 2 general medicine hospitalist services. And what they found was, first of all, 40 patients had pending test results at the time of discharge. 9% were judged to be actionable, but outpatient physicians were unaware of 60% of these. And the significance of that is that since they were cared for by hospitalists on the inside, no one was going to follow these up. And they agreed that about a third of them were actionable, and that they required urgent action in 13%. So this included, actually I'll just skip this. This included things like there was a patient admitted with atrial fibrillation that was rapid. Their TSH came back at less than 0.01. So this was a new diagnosis of hyperthyroidism. No one knew about it. No one followed up on it. Wrong antibiotics based on the eventual culture results. There was a radiology example that, even though it wasn't urgent, was obviously very serious. A CT had been ordered to rule out pulmonary embolism, and it ended up showing lung cancer, and no one really knew about the result or was going to follow up on it. So if you actually break down these numbers differently, what it really means is that among all discharged patients, 2% had important test results that were very unlikely to be followed up by anybody, and urgent action was required a third of the time. And studies of specific tests have also shown substantial rates of losses to follow up. I give an example here with bone densitometry results, another one with thyroid tests. So this is a hugely important problem, I think, for clinicians and laboratory people to tackle, and maybe also for informaticists, although I was talking to Mike and an informaticist here earlier, and it's not clear what the solution is. I mean, I cannot tell you, what, as a clinician, it is a constant source of anxiety to me to know that there's all these patients that I've ordered tests for, and I don't really know what's going on with the follow-up of those results. And I know as a lab, obviously, even keeping track of critical labs is hard enough, that how to do it routinely for all of these other labs, but it is an important problem because there are so many people whose care is fragmented. If there's not a way of easily seeing who has dangling test results that need to be followed up on, there's going to be more problems like this. An example of an intensive laboratory sort of clinic collaboration was a follow-up of that discrepancy study I was mentioning. They implied this so-called industrial-style quality improvement. They specifically called it Toyota-style production model to look at the workflow from everything from obtaining the pap smear to eventually looking at the pathology. And they showed a statistically significant reduction over, I think it was a couple of years of working with this gynecologist in the lab, working together, that the percentage of pap smears that were lacking in a transformation result zone decreased by about half, and that was statistically significant. The diagnosis of atypical squamous cells of unclear significance decreased. Obviously, those are not very useful diagnoses clinically, so it's good to be able to reduce that by half. And this was not statistically significant, but it's still an interesting trend that they actually reduced the number of discrepancies. I mean, when you first hear about these discrepancies, you sort of think, well, what's the big deal? You'll look at some of them and you say, well, actually a decent proportion of them look significant. Now they're able to reduce the percentage of them. I think that is very promising. A lot of times in patient safety, I feel like when I give a talk, I'm like in this situation where I'm saying, well, there's all these problems, and then here's some solutions, but they have problems too, and the name of this problem is a slip, and the name of this problem is a mistake, and ultimately, well, what are you supposed to do? I think philosophically, I just remind myself that, well, you know what, there's a field, the whole thing is only about 5 years old. And so when you think about what you would expect, like if you take seriously I showed this slide earlier, that medical error is the 8th leading cause of death. If you take seriously a disease analogy and think of medical error as a disease, you have to accept that you're not going to cure cancer in 5 years. I mean, the war on cancer has been going on for 30 years. I mean, if you think about HIV in the initial years, it was slow growing, and now we have these wonderful drugs that have really radically changed changed clinical care, at least in developing countries. So I think we would not expect huge changes within 5 years. I think we're only now even recognizing what the appropriate basic sciences are for patient safety, and they include some kind of amalgam of psychology and organizational theory and regular clinical research. But still, I think there are some recommendations that can be made. I think that, first of all, in terms of the epidemiology and identifying the problems, that the trigger methodology is a very efficient way of identifying patient safety problems in whatever area you work. I think it is crucial to distinguish these cognitive and non-cognitive errors to avoid this sort of mismatch where it's like another example of a non-cognitive error being responded to with an educational in-service or some other just work harder, pay more attention, and so on. Process redesign and automation, I think, are crucial, especially in the laboratory. In fact, maybe the lab may be the most amenable to this in all of healthcare, but it's, expect the unexpected. There will be these unintended consequences, workarounds maybe that are created. The culture of work needs to change sometimes in order to really have meaningful process redesign. And then I also think that it's important, even though internally I understand the distinction between pre-analytic, analytic, and post-analytic, if you really want to make meaningful progress, a lot of these pre-analytic and post-analytic errors will have to be addressed sort of collaboratively between clinicians and non-clinicians. And with that, I'd like to say thank you very much.